So now I request Dr. Deependra Vikram Singh as a Medical Director, Retina Services for IQ Hospitals, to give his talk on displacement with gas alone, without going for the fancy TPA and anti-VEGF. Is it underrated? How to get a large bubble and success rate? Thank you, Dr. Deependra.
It's on there. Yeah, thank you, Dr. Reddy. And I think Dr. Avnish has done a wonderful job setting the context that why we need to get rid of this blood and what are different modalities. And you all must have seen when these cases they present to our clinics, it's most of the times a very acute presentation. And some of them are already a known patients who are taking anti-VEGF injections, and they give you a call that I'm not able to see anything. And first thing that comes to your mind is that poor guy must have developed either some macular hemorrhage or RP rip, right? So it is a little an acute emergency kind of situations for us. So and how do we treat it? I think again very nicely listed by Dr. Avnish that we have two options only. Either we can displace it or we can remove it. And prognosis, if you ask me, the most important factor which would determine the prognosis is the height of heme at the fovea itself. And of course, chronicity and underlying pathology which has led to this bleeding is also going to influence the prognosis. So pneumatic displacement is not new, and we use gas for so many different reasons. So everybody is familiar with now gas and its properties. And I'll just straight away walk through few cases and then try to make a point, which is the title of my talk. So this was again a post-traumatic submacular hemorrhage in a young patient, and those days we were not doing that many OCTs for these cases, and our understanding of OCT for submacular hemorrhage was limited. But we were doing FFAs to rule out any other reason. And this patient, we injected gas and followed by prone positioning. You can see the shadow here. And over the next 6 to 8 weeks, blood resolved nicely. And you may argue that it may not have displaced, it might have just absorbed. So, but just have a look at this white field montage, and you can see that all the blood has shifted downwards because of that prone positioning. And if we would not have displaced this blood, you would have ended up this kind of accumulation and scar and organized clot at the macula itself. So point what Dr. Avnish was telling, that this looks like a small extent of hemorrhage, but there was a lot of blood lying at macula. I didn't have the OCT at that time for this patient, so we couldn't measure the height, but you can see that displacement made a huge difference to this patient. But I think eye-opener for me, especially in those days of practice, was this patient. She was a 65-year female, and she had a history of sudden loss of vision for last 1 month. And you see the extent of submacular hemorrhage. In all the studies where they evaluate the interventions, they label it as big, large, massive hemorrhage when it is spanning across the arcades. So, and this was a lady who would not be eligible for any kind of surgery, or she would not be able to afford TPA even. So I said, let me try gas as a trial. I'll give you gas same day, today itself, and ask you to do prone positioning. And she was quite obese. So we did that, and you see this, what happened after just 2 days of gas injection. And what you can notice is we got a really large gas bubble in this case, which is coming down. The meniscus is below the arcade. And that is how you can judge the size of your gas bubble. So because of that large gas bubble and immediate prone positioning, she got significant displacement. And we could do it same day, and rather her pressure became very high. I had to do paracentesis 2 times to get that large bubble. And end result was quite satisfactory. She came to us with 3/60 and almost a lost eye, and with followed up with anti-VEGF injections, she could regain 6/36. So something I learned from that case is it is never too late. If you get a red-looking, dark-looking submacular hemorrhage, give it a try. It might still displace, and you can change the final outcome. So the point what I am trying to make is, why gas alone? There are now treatment options available, TPA, that you can go subretinal, you can do more extensive surgery. But for me, gas injection is like a first aid. Whenever patient lands into our retina clinic, the gas is always available with us. You can offer it then and there only. And that is what I tell all my interior colleagues also, send patient prepared for gas injection at least. And so TPA and all other anti-VEGFs, you will have to get approvals, arrange for it, patient has to be ready for that. And interestingly, it will do job for most small and moderate size hemorrhages and significant number of large submacular hemorrhages also. And I am not a big fan of intravitreal TPA these days. For me, because of the cost involved, I would prefer to inject it subretinal rather than giving just intravitreal. And it has not been proven to be better than subretinal TPA in any of the comparative studies. And if you eliminate the impact of gas and pneumatic displacement, it's very difficult to judge the impact of intravitreal TPA. I'm not talking about subretinal TPA. And the fourth argument in favor of gas alone is you can always go for a stepwise approach. Inject gas, make prone positioning, ask patient to come back after 3-4 days. And if you have some failures, patient gas is not, blood is not getting displaced, you can then proceed for vitrectomy. And another thing which I am quite against is going for a cocktail kind of treatment, giving intravitreal anti-VEGF also immediately, because they are less likely to penetrate thick clots lying over the CNVM or polyps. So it makes sense to inject gas, displace the blood, and then you give anti-VEGF after 3 days or 5 days. And of course, shifting is not a one-time affair. We have seen it. You shift it with gas and you feel that shifting is still not adequate. You can go ahead with vitrectomy and shift it further. So it's not that once blood has shifted, it gets organized immediately. So stepwise approach, you have nothing to lose. That is the point I wanted to make, and I'll show a few more cases in support of that. So again, this was a very old case. I was managing his right eye. In fact, his son was a very senior scientist with Genentech, and that's the reason he was sticking to Avastin only. And the meanwhile, his left eye, he presented with a CNVM and hemorrhage, which we have never treated. So these fellow eyes definitely are at higher risk. And we injected gas and it shifted temporally. And you can see, and then we treated him with Avastin, the left eye also. He had second episode, second time also gas injected, no TPA. Again it shifted nicely. And then he had a third massive episode. At this point of time, I asked him for surgery, and somehow then I think he was lost to follow up. So, but the point is that even recurrent bleeds, they also shifts nicely with just gas without any TPA. Now, another, I think this case I wanted to share exactly to highlight the same point what Dr. Avnish was pointing out, that sometimes you feel that it's a very small amount of hemorrhage lying at macula. And this is the one-eyed gentleman who has lost other eye to advanced AMD. But if you see, when we do scan, you can see a very tall accumulation, a significant height of subfoveal heme. And that was correlating with his visual acuity, 5/60. So again, this is the case. We will go ahead with just gas alone, no TPA. And this is a picture at 3 days, and you can see at 1 week, significant reduction in the subfoveal heme. And blood has shifted temporally and inferiorly. This is again one point I wanted to highlight. When you are planning to displace blood, always realize that this blood is going to shift down and temporally. So the amount of blood which is lying above fovea and nasal to fovea, the extent of that blood also you should take into consideration when you are planning your approach. So I think this was again a patient with polyp. She came with subretinal fluid and PED, and we were planning ICG, but she had another episode of bleeding, and blood was now subfoveal. And you can see the difference. When blood was not in the subfoveal area, the visual acuity was 6/18, but it dropped to 5/60, and now she has blood. So our plan changed now. Of course, polyp was there, but we injected gas, and it shifted nicely. Another patient with large amount of blood superior to fovea. Now, for me, this is a massive hemorrhage because I have to displace all this blood away, down and temporal. So I will go for a larger bubble. Again, you see the meniscus of the gas bubble. It's reaching right up to the arcade. Another patient having a significant blood in the seeing area, despite the patient having this scar, again shifted. So the next question is, how do we achieve bigger bubble and get significant displacement with just gas alone? One, I think, modification which I have been doing for almost 10 years is I do not inject pure gas. What I do is I take 0.2 ml of C3F8 and then I make it 0.6 ml by adding air through the filter. so that now I have 0.6 ml of minimally expansile gas in 1 ml syringe, and I try to get a very big bubble on the table itself. And if IOP starts getting high, if once you cross 0.4, 0.5 ml, so I do parasynthesis and check for light perception. If light perception is not brisk, and you can check it with microscope, if light perception is not brisk, I normally would go for second round of parasynthesis. So I'll just show this video. I think I'll wind up just last case. Again, a young lady with PCV and subfoveal hemorrhage, and you see the extent is not big, but you see the height. Sub-RPE and subretinal blood is huge. So this is the technique. Incidentally, we have recorded this, but normally we would not record intravitreal gas injection, but this was recorded, I think, last year, just to show that how you inject gas in these cases. All my VR colleagues, they know it. You have to stay in the bubble, withdraw the needle, and this was a fairly large amount of gas bubble we could achieve. Minimally expansile C3F8, and here I am using microscope light to check the light perception. I realized that even after parasynthesis, it's not going down. So I will do this very rarely, but here I reduce the size of gas bubble just to ensure that light perception comes back. And you can see, even with that size of bubble, a significant displacement happening in this case, and a significant amount of blood getting away from fovea. You can see the height going down. And because I have reduced the size of bubble, the meniscus is upper. And in long run, she did well. So to conclude, I'll say yes, pneumatic displacement alone as an intervention has been underrated, and it's a viable alternative. Especially, it's a low cost and immediately available. So that is the huge advantage. And it doesn't interfere with additional interventions. If you need to do vitrectomy or anything subsequently, it doesn't interfere with that. So thank you.
Thank you, Dr. Deependra.